All right. Today we are going to talk about thyrotoxicosis. So these are going to be hyperthyroid patients, right? Thyrotoxicosis is just a fancy way to say hyperthyroid. I have two Instagram cases that I posted that kind of relate to this, so we'll talk about both of them. And then we'll go through a little bit of like the thyroid physiology, and then we'll go through the framework for actually thinking through thyrotoxicosis. So I'm not going to talk about hypothyroidism today. That'll be its own lecture. Otherwise, this will get way too long. I'm going to give you a real nice, easy framework to use. I learned a lot of it from Dr. Mansour's framework for internal medicine. It's such an easy schema to use that'll literally help you answer any question you get about hyperthyroidism or use it in the clinic, right? Where we're actually like focused on going. So I pretty much talk about all this, and then I have two different putting it all together cases. Okay. So this was the first case I considered for us. So let's think about this one first. So we have a 56-year-old female presents to the clinic for a 1 month history of sweating, increased palpitations, 7-pound weight loss, and new right-sided tremor. Proptosis is noted on physical exam. 24-hour urinary metanephrines are within normal limits. The patient opts for pharmacotherapy. She's put on 2-agent treatment per standard guidelines. She presents 3 weeks later with fever to 101.7 and has a sore throat. Absolute neutrophil count is 200. What is the next best step? Should we initiate Metro? Should we initiate amoxicillin? Should we initiate Vanco? Or should we initiate cefepime? So pause the screen, try to think about what the underlying condition is going on here. What do we put her on? What's going on? And then what should be our next best step? All right. So with this patient, right, this is a classic hyperthyroidism symptoms, and we'll talk about why she's having these symptoms when we get to the physiology. But I see sweating, palpitations, weight loss, a new tremor. Proptosis is classic for Graves' disease. We see that the metanephrines are within normal limits, and we got that. I'll do a lecture on FEOs or MEN syndromes probably pretty soon here. But we want to probably rule out a pheochromocytoma because that and hyperthyroidism can look awfully alike, right? Because both are going to be due to adrenergic excess, and pheo, it's because we have a medullary tumor secreting excess norepi and epi. In hyperthyroidism, due to X, Y, or Z, it's because my thyroid hormones T4 and T3 actually upregulate adrenergic receptors. So we put her on, she opts for pharmacotherapy. We put her on 2-agent treatment. So 2-agent treatment is going to be a thyroid blocking agent like methimazole. PTU really only has two uses. PTU, and I have a slide on this, but PTU is used in the first trimester of pregnancy, and it's used in thyroid storm, and we'll talk about both of those reasons why coming up. But so this patient would probably put on methimazole, okay, not PTU. PTU is less preferred because it can cause really, really bad hepatotoxicity. Um, and then we put her on a beta blocker as well. So the 2-agent standard treatment would be some sort of beta blocker and then a thyroid blocking drug. The beta blocker is to stop the adrenergic effects of these increased amount of thyroid hormones, right? Okay. The problem is methimazole and PTU can both cause agranulocytosis. It's a very common side effect. Other drugs you're going to want to know, like just off the top of my head, are clozapine and TMP SMX. Those are both so TMP SMX, clozapine, methimazole, and PTU are some of the most commonly tested drugs that cause agranulocytosis. So they're going to want you to know those for USMLE. We consider neutropenia when the ANC is less than 500. This patient's well below 500. She has a nice little fever going and a sore throat. This is classic for febrile neutropenia. This is a medical emergency, absolutely, because when the patient has very low neutrophil counts, it allows certain bugs to kind of run free. And the big bad bugs we're really worried about are gram-negative rods. And the one that we're most concerned about is Pseudomonas. So we need to pick a drug that will cover for Pseudomonas, okay? Metro is really great for anaerobes, not Pseudomonas. Amoxicillin can cover a lot of my gram positives, a little bit of gram negatives, but definitely not Pseudomonas. Vanco is really good for gram positives, so like your MRSA and ceftriaxone resistant strep pneumo. Not going to cover Pseudomonas. Cefepime, absolutely. So this is all coming from the American Society of Clinical Oncology and Infectious Disease Society of America. They recommend the next best step when we see febrile neutropenia is to initiate empiric intravenous therapy with an anti-pseudomonal beta-lactam. Okay, so among the options listed, cefepime is the best answer, right? Because cefepime is a beta-lactam, it's a cephalosporin. This is a fourth generation cephalosporin, so it actually has the capability of covering Pseudomonas. Remember, other cephalosporins that can cover Pseudomonas are a third generation called ceftazidime. Ceftriaxone, also a third generation cephalosporin, does not cover Pseudomonas. Don't get ceftaz, cefepime, and ceftaroline confused. Okay, they're often confused by students. So ceftaz and cefepime can both cover Pseudomonas. Ceftaroline is my new fifth generation cephalosporin that actually covers MRSA, but it doesn't cover Pseudomonas. Okay. And then, they recommend intravenous therapy. Amoxicillin actually is also a oral drug, right? So another reason why it's wrong. So these drugs will cover a broad spectrum, including Pseudomonas, which is guideline recommended as first-line therapy. Vanco, again, is not indicated as part of that empiric therapy unless there's specific clinical indications, such as hemodynamic instability, not seen here, suspected catheter-related infection, a skin or soft tissue infection, or known colonization with resistant gram-positive organisms, none of which were described in my case, right? So Vanco would be covering for MRSA, but I didn't give you anything like a skin or soft tissue infection, a catheter, known colonization with big bag gram-positives. Metro, again, is anaerobic. Amoxicillin would not cover for Pseudomonas. So again, they're talking about given the cefepime at a typical dose of 2 grams IV every 8 hours, and then adjust for renal function, and then we'll kind of move from there. All right. Here is a article that if you want to read more about febrile neutropenia and kind of the management, I would screenshot this and throw that into Google and read more. All right. So just a little bit more on why are we scared of Pseudomonas and febrile neutropenia. So neutrophils are critical in the defense, okay, against Pseudomonas. Profound neutropenia, less than 500 and especially less than 100, increases the risk of severe Pseudomonas infection. So this can cause rapid fulminant bacteremia and sepsis, high morbidity, and high mortality. So again, empiric anti-Pseudomonal coverage is required in all cases. That's from our American Society of Clinical Oncology and IDSA. Pseudomonas is intrinsically resistant to many antibiotics, and it can acquire additional resistance. So again, my first-line antibiotics for Pseudomonas can include cefepime, piperacillin tazobactam, carbapenems. Okay, there are other drugs that can cover Pseudomonas as well beyond the lecture today, but some things can be like aminoglycosides, monobactams, your fluoroquinolones, and those would probably be polymyxin would probably be the other one that comes to mind. But really, I want you to think about a beta-lactam. So we're going to think about cefepime, pipe-taz, and carbapenems. So even minor mucosal breaches like the oropharynx or GI tract can lead to extreme bloodstream invasion when the patient's neutrophil count is low. So that applies to all neutropenic patients, right? Including drug-induced, like here in our antithyroid. So here's the journal article where I learned all that from several months ago. Really good article to read about. So again, take home point for this. The 4 common drugs that USMLE likes to test about that can cause neutropenia: clozapine, TMP-SMX, methimazole, PTU. Absolute neutropenia is considered when my absolute neutrophil count is less than 500. When the patient is febrile, and especially like a sore throat is kind of also classic when they're febrile and they have neutropenia, that's called febrile neutropenia. That is a medical emergency. We need to start treating with IV beta-lactams that will cover for Pseudomonas. Some of my options include cefepime, piperacillin tazobactam, and then certain carbapenems, okay? Really, really important. Just remember Pseudomonas. Let's cover for Pseudomonas. Step 1, they might just ask you which bacteria. You're going to say the gram-negative rod, that's oxidase positive. All right. So please remember that. All right. I'm sick of these Grammarly things. All right. So our other case to consider that I put up today, we have a 23-year-old woman presents with 2-week history of palpitations, sweating, and heat intolerance. The EKG demonstrates an irregular rhythm. No thyroid bruit is appreciated. Exophthalmos and pretibial myxedema are not present on exam. TSH is low and free T3, T4 are elevated. Radioiodine uptake scan demonstrates decreased uptake of the tracer. Which is the most likely cause of our symptoms? Is this Graves'? Is this struma ovari? Is it a toxic adenoma? Or does this patient have impaired sensitivity to thyroid hormones? So pause your screen and think about it, and then we'll talk. So in this case, this would be struma ovari. And again, we're going to go over my framework on how to easily think through this. But really, the clinical picture, we have the palpitations, heat intolerant sweating. We have an irregular rhythm, which would be AFib, right? Increased thyroid hormones, increase my sympathetic nervous system activation via increased beta adrenergic receptor production, which can increase the sympathetic tone of my heart and can actually lead to AFib. My lab showed decreased TSH. So this is a TSH independent cause of thyrotoxicosis and free T3, T4. Again, we see the AFib. The key thing that points me here is we see decreased radioiodine uptake. Okay. So when I look at that, right, and I look at things like Graves' disease, and we'll flesh these out a little bit more. The Graves' disease is going to have diffuse uptake. Okay. Toxic adenoma is going to have increased uptake, and it's going to be focal. TH resistance, we'll see normal or high TSH. In this case, we saw low TSH. So again, we're going to talk about all these in depth, but really, struma ovari is an ectopic thyroid tissue found in ovarian teratoma that produces T4, T3. Those T4 and T3, they feed back and they shut down the production of TSH. So we see low TSH. Because there's no TSH or very low TSH, there's nothing really stimulating my thyroid. So my thyroid itself, the gland, is not overactive. And actually, it's going to be somewhat suppressed because my body, my brain, my pituitary is thinking, hey, we're getting enough thyroid hormone. I don't need to make TSH. We don't need to stimulate my thyroid gland. My thyroid gland suppresses. So when I do a radioactive iodine uptake, the thyroid gland itself is not going to uptake a lot of that tracer, right? So really what I want you to think about is when you see a low radioiodine uptake and thyrotoxicosis, we're thinking about destructive, exogenous, or ectopic causes. So destructive would be thyroiditis. Exogenous would be factitious thyroiditis or factitious thyrotoxicosis, so a patient taking levothyroxine. And then your ectopic would be struma ovari. Again, we're going to talk about all these in depth, but really the thing here, I see a TSH independent thyrotoxicosis that puts me in one place on my schema, and then I see the decreased radioactive iodine uptake, which puts me in another place on my schema. The only one that fits that option would be struma ovari because Graves is going to have increased and diffuse uptake. Toxic adenoma will have increased and focal uptake, and TSH resistance or thyroid hormone resistance, would cause normal or high TSH. And we'll flesh these out coming up. So to first start, we need to quickly talk about the hypothalamic pituitary axis that I already kind of just mentioned, but we need to just kind of make sure everyone's on the same page. But we have sitting in our hypothalamus, it secretes thyrotropin releasing hormone that goes down to the anterior pituitary, and it says, hey, make TSH. So the anterior pituitary makes TSH. TSH does exactly what it says. It's thyroid stimulating hormone. It goes to the thyroid gland, and it increases the production of T4 and T3. Really, not too much T3 comes from the thyroid gland. A lot of it is going to be converted peripherally, and I've got that on the next slide. But again, in a little bit of T3 gets made, a lot of bit of T4 gets made thanks to TSH from the anterior pituitary. Those go down to the peripheral tissues, and like I said, there's this enzyme called 5' deodenase that converts T4 to T3. T3 is by far the more metabolically active hormone. So it kind of allows our tissues, our peripheral tissues, to say, hey, I need more thyroid hormone than just T4 is going to offer. Let me upregulate 5' deodenase so I can make more T3, which gives me more bang for my buck. Or maybe the tissue's like, hey, we don't need as much thyroid hormone. I'm going to downregulate 5' deodenase, and I'll just take whatever T4 you give me. So physiological effects, we have increased basal metabolic rate, increased protein synthesis, increased beta adrenergic sensitivity, and this is going to be critical for growth, development, and CNS maturation. So maybe you learned at some point, right, if the kid, if a newborn has a hypothyroidism, right, that's extremely severe, because if they don't have functioning thyroid hormone, they're going to be really bad on all these areas, and the patient could have like irreversible neurological damage, right? So usually the most common cause of hypothyroidism in a little kid is, take a second to think about it. So it's usually thyroid dysgenesis. So for some reason, the thyroid gland itself just didn't get made, okay? Didn't get made properly or didn't move to the right spot properly, and it's not functioning the way it should be, all right? So again, in the negative feedback loop, the high T3, T4 levels, they move back to the hypothalamus, into the anterior pituitary, and say, hey, we're good. Stop making TRH, stop making TSH. So again, hypothalamus makes TRH, talks to my anterior pituitary, says make TSH. TSH talks to my thyroid gland and says, hey, make T4, T3. T4, T3 go down to peripheral tissues. A lot of the T4 gets converted to T3, which is more metabolically active via the enzyme 5' deiodinase. Those together are going to increase basal metabolic rate, protein synthesis, beta adrenergic sensitivity, and then the high amounts of T3, T4 feedback and shut down TRH and shut down TSH. All right, moving along. So this is probably more than you would ever need to know, especially for step 2. For step 1, might come into play. How does a thyroid hormone get made? We get iodide trapping. So this the sodium iodide symporter brings iodide into the follicular cells via active transport. We then oxidize the iodide via the enzyme thyroid peroxidase. Okay. The iodine then gets attached to tyrosine. That would probably be the most important thing I would know, is that the tyrosine and amino acid is really important for thyroid hormone production. Okay. If we add 1 iodine to tyrosine, it's called MIT. If we add 2 iodines to tyrosine, it's called DIT. We can do a coupling reaction where we add an MIT to a DIT, and that makes T3. Or we can add a DIT to a DIT, which makes T4. And hey, guess what? Same thyroid peroxidase enzyme. To store them, the iodinated thyroglobulin is now stored in colloid. And then we wait until we get secreted, right? When we do endocytosis and proteolysis, the thyroglobulin is reabsorbed into the follicular cell. A protease will cleave that thyroglobulin into free T3 and T4, and then they'll get released into the circulation. And again, they'll go to the peripheral tissues. T4 can get converted into T3 via the 5' deiodinase. Big things I want you to take away from this. You definitely do not need to know this whole thing, but we see thyroid peroxidase showing up in multiple steps. That's going to play a really important role when we talk about hypothyroidism, because there are certain hypothyroid diseases where we get antibodies to thyroid peroxidase. Hashimoto's thyroiditis is the most common one. And so when we have damage to this enzyme, we can't do this whole process and we can't make thyroid hormone. That'll become important when I do my hypothyroidism lecture. The other thing I want you to remember is that tyrosine plays a really important role in the kind of production of thyroid hormone. All right, so thyrotoxicosis management. Let's just talk quickly how we manage these patients. We do symptom control with beta blockers. So again, that will decrease the adrenergic symptoms, and then it will decrease the conversion of T4 to T3. That's because that 5' deiodinase, drugs like propranolol actually decrease the activation of 5' deiodinase. So I can give a drug like propranolol, and not only will it block my adrenergic receptors, obviously in this case my beta receptors, right, because it's a non-selective beta blocker, but it'll also decrease the conversion of T4 to T3, limiting the production of the really potent hormone. We can decrease the hormone synthesis itself with the thionamide drugs we've already talked about, things like methimazole, which is first line, and things like PTU, which I told you is used in the pregnancy in the first trimester and thyroid storm. So PTU is used in pregnancy in the first trimester because methimazole has been shown to cause aplasia cutis, or has an increased association with aplasia cutis. That's where the baby is kind of goes through embryology and its skin doesn't fully form. Okay, so obviously very, very bad. So that's a huge problem during the first trimester with methimazole. So I actually put the patient on PTU during the first trimester. Once they get into the second and third trimester, we put them back on methimazole. Okay, that's because methimazole works a little bit better and it has less overall side effects, except for in the first trimester of pregnancy. PTU is also a great option in thyroid storm, because in thyroid storm, we have an overwhelming production of thyroid hormones that causes huge damage to the body. I've got a slide on it coming up. We can use things like PTU because, one, it will stop production of thyroid hormones in the thyroid itself, but it also decreases the conversion of T4 to T3. All right. Other drugs that can do that are things like glucocorticoids can also stop the production of T4 to T3. So the three things that can stop the T4 to T3, the three big ones you're going to want to know are propranolol or beta blockers, PTU, and glucocorticoids. Okay. So the three big drugs you're going to want to know that can block the conversion of T4 to T3, they block 5' deiodinase, PTU, propranolol, and steroids. So again, these drugs, methimazole and PTU, they inhibit TPO. They block that thyroid peroxidase enzyme that I was just talking about. That's super important. And it blocks T3, T4 synthesis. We can use iodine, which causes the Wolff-Chaikoff effect. So basically, I give an overwhelming amount of iodine, and it tells the thyroid hormones like, yo, dude, we're good. And it shuts down the production of any more thyroid hormone, okay? Because it thinks it has way more iodine, which it does, right? And it doesn't need to make any more thyroid hormone. We can reduce the peripheral conversion. I already told you about glucocorticoids, inhibit T4 to T3. So again, it's used in severe cases and thyroid storm. We can do definitive therapy with radioactive iodine ablation. So in this case, we shoot radioactive iodine at the thyroid, which will ablate it. It'll destroy the thyroid tissue. Or we can do surgery, okay, to actually remove the thyroid hormone itself. When I do surgery, we have to be very careful. We have our recurrent laryngeal nerves that run right next to the thyroid. So those are really important for my vocal cords, right? Every muscle in my larynx is innervated by the recurrent laryngeal nerve, except for the cricopharyngeal muscle, which is innervated by the superior laryngeal nerve. The other thing I want to be careful of is post-thyroidectomy, is the patient can develop hypocalcemia secondary to hypoparathyroidism. So I have 4 parathyroid glands that sit right next to my thyroid. If we don't find them, because they're very, very small, the surgeons do an absolutely amazing job looking for the nerves, looking for the parathyroid glands. Unfortunately, sometimes they're just embedded within the thyroid tissue. We can't see them. Really, a patient is able to manage maintain normal calcium levels if they just have a half of a parathyroid gland left, right? So we have 4. We could take out 3.5 of them. And as long as they have a half in there, they're usually able to maintain normal calcium. But sometimes we can take out enough that the patient then develops hypocalcemia. I'll do a whole lecture on parathyroid, but if you don't have your parathyroids, you can't manage your calcium as well, and your calcium levels drop. So contraindications to radioactive iodine would be pregnancy, breastfeeding. We could do surgery for a large goiter, compressive symptoms, and if there's a malignancy risk. Special situations, again, I told you, thyroid storm management. I'm going to send them to the ICU. We're going to use a beta blocker, PTU, iodine, a huge amount of iodine to shut that thyroid down, and steroids. And then pregnancy, I told you, PTU is used in the first trimester, methimazole in the second and third. All right, thyroid eye disease really quick. So the pathophysiology, we get autoantibodies from the TSH receptors or IGF-1 receptors that stimulate the orbital fibroblast. So really, this classically occurs in Graves' disease because we make these thyroid stimulating immunoglobulins that can also not only stimulate the thyroid gland, they can go up to my eye fibroblasts and stimulate those fibroblasts. So when those fibroblasts get stimulated, they cause an increased amount of inflammation, an increased amount of fat production. These glycosaminoglycans, which are going to be the driving force here, that are going to push the eyes forward. So glycosaminoglycans are like those extracellular matrix that builds up behind the eye, increases the pressure, and can cause proptosis. So these can lead to proptosis, diplopia, optic neuropathy. We have active and inactive phase. So the active phase has inflammation, edema, lymphocytic infiltration. The inactive phase has fibrosis and fat infiltration. So if it's a mild or inactive disease, we can use lubricants, selenium, and observation. If it's moderate to severe, steroids. We also have this newer drug called teprotumumab, which is an IGF-1 receptor inhibitor. So again, that IGF-1 receptor is key in the pathophysiology because the autoantibodies are going to target these IGF-1 receptors on the fibroblast. So let's block those receptors. All right. We can also use mycophenolate, rituximab, and tocilizumab. Tocilizumab is an IL-6 inhibitor. If they're sight-threatening, high-dose steroids, orbital decompression. If it's inactive or they're rehab, we can use decompression. We can do different kinds of surgery. Okay. So again, the pathophys, we have these thyroid stimulating antibodies that can go up to the orbital fibroblasts. They can stimulate via TSH receptors and IGF-1 receptors. Those stimulate those orbital fibroblasts. We increase inflammation. We increase these extracellular matrix. causes my eyes to pop out, we can use steroids, and teprotumumab are going to be the go-to on what they're going to test you on USMLE step 1 and step 2. All right, Birch-Rutofsky score. This is just for your information. This is how we score thyroid storm. Okay, you do not need to memorize this, but the difference between thyrotoxicosis and thyroid storm is a fine line. Okay, because thyrotoxicosis can really quickly move into thyroid storm, and we kind of grade it based on this, right? If their temperature's above 104, if they're got agitation, they've got seizure, coma, if they're nausea, vomiting, diarrhea, jaundice, if their or their heart rate's over 140, if they have edema, pulmonary edema, if they have AFib, or we have a known precipitating events, can all get us points. If the patient has a score of over 45, they're likely in thyroid storm. If it's 25 to 44, the storm is pending. And if it's less than 25, it's unlikely. So again, I told you with thyroid storm, we usually admit them to the ICU. We get beta blockers, PTU, iodine, and steroids. And we're going to have to watch really closely. So again, this is more for your information, not anything you would need to know to calculate on an exam. But basically, like a USMLE vignette could just give you a patient who's got really, really bad thyrotoxicosis. You should think about thyroid storm. All right. So now we get into the meat and potatoes, and we'll go through the schema pretty quick here. How I think through thyrotoxicosis, this will help you so much. All right. So how can we further break down thyrotoxicosis? I can break it down 2 ways. So pause your screen and think about how you would want to classify a patient with thyrotoxicosis in broad buckets. So I think about thyrotoxicosis as TSH independent or TSH dependent, right? So is TSH running the show? Do we have an increased amount of TSH that's stimulating my thyroid hormone? Or is the thyroid hormone coming from somewhere else and actually inhibiting TSH? So I don't need TSH in the process. So now I want you to think about what are the causes of TSH dependent thyrotoxicosis. So there's 2 big ones that we're going to discuss. What do you think? Pause your screen. So the 2 big ones are going to be a TSH secreting pituitary adenoma and thyroid hormone resistance. Okay. So in TSH secreting pituitary adenoma, we're going to have our hyperthyroidism signs. You know them by now: palpitations, heat intolerance, weight loss. And then we might also see mass effects. So remember, my pituitary sits on my sella turcica, and right here's my pituitary. Right above it is my optic nerve that crosses. And if the pituitary has extra mass to it, it can compress right at the optic chiasm, and the patient can lose peripheral vision bitemporally. So that's called bitemporal heminopsia. The patient may also have headache, okay? So we're going to see this tumor is going to secrete increased amount of TSH. So there's increased amount of TSH. It's going to stimulate my thyroid. We're going to make more T4, T3. If the TSH keeps stimulating the thyroid, they could get a goiter, right? There's 2 main ways we get goiter. One is by increased stimulation of the thyroid gland. So maybe it's by TSH itself, maybe it's by the thyroid stimulating immunoglobulins and Graves, or we get inflammation. So something like Hashimoto's, those patients get goiter usually secondary to lymphocytic inflammation, secondary to this extreme inflammatory process in their thyroid. So the pathophysiology, we have an autonomous pituitary tumor that's just constantly secreting TSH, and it's not listening to negative feedback, okay? So key diagnostic clues, really, we could see a high alpha unit, subunit of the pituitary hormones. We're probably not going to test for that, but we'll see no TSH suppression if we do a T3 suppression test. So we basically give the patient exogenous T3, and that should suppress the hypothalamus and the anterior pituitary. If we have a tumor that's just autonomously secreting this TSH, it doesn't play by our normal HPT rules, right? My hypothalamus pituitary thyroid rules. And it's going to say, F you, I'm not listening to you, and it's going to keep secreting, all right? We could also see a pituitary mass on the MRI. So the management, we usually go for transsphenoidal resection. We can give somatostatin analogs like octreotide, and very rarely are we going to use dopamine agonists. Okay, obviously we can treat the hyperthyroidism symptoms via thionamides and beta blockers. Okay, so my pearl for this one is it's a true central hyperthyroidism. So the TSH drives the T4, T3. I want to say for both of these, though, you have to be very careful, right? If we have a tumor secreting too much TSH, and then we get too much T4, T3, if those T4 and T3 get high enough, they can feed back and somewhat suppress the TSH. So you might be looking at the labs and their T4 is like 10 times the normal limit, something like that, right? It's like super high. And you're like, whoa. And you look at their TSH, and you might think, hey, the TSH is going to be high, right? Because it's a TSH secreting tumor. You have to be careful because if the T4, T3 are high enough, they can somewhat suppress the TSH. And now my TSH, let's say it's within the normal limits. And you're like, the T4, T3 are both elevated. The TSH is within normal limits. So to me, that's abnormally normal because normally when T4, T3 are sky freaking high, they feed back and my TSH should be undetectable, right? It should be way below the normal limit. So the fact that it's normal tells me there must be something up in my brain that's autonomously secreting TSH, and the high level of T4 and T3 have just brought it somewhat down into the normal limit. Sometimes you'll see that the T4, T3 aren't able to suppress it, and your TSH will be high and your T4, T3 will be high. That immediately points me to somewhere in the brain. There's something in the brain secreting TSH going down to my thyroid, and it's telling it to, hey, make more T4, T3. So then we have thyroid hormone resistance. It's often asymptomatic. You might see mild hyperthyroidism or maybe euthyroid. And there's sometimes a family history. Again, an increased TSH, increased free T4 and T3. It's due to mutations in the thyroid hormone receptor, usually the thyroid receptor beta gene, and the tissues are variably resistant to thyroid hormone. So basically what happens here is TSH is working fine, your thyroid hormones are working fine, but the TSH receptors aren't totally responding the way they should be. So again, normally when T4, T3 get high enough, they should feed back to the hypothalamus and they should feed back to the anterior pituitary and say, hey, no more TRH from the hypothalamus, no more TSH from the anterior pituitary. The problem is those receptors that are responding to T4, T3 aren't totally working correctly, right? So your anterior pituitary and hypothalamus don't see this high level of T4 and T3 because the signal's not being sent properly from the T4, T3 binding to those receptors. That signal doesn't get sent properly. So your body, your brain, your hypothalamus and anterior pituitary think you have very low amount of thyroid hormone, so it keeps secreting more TRH and TSH. So again, key diagnostic clues, we'll see a family history maybe, normal pituitary imaging, and no mass effect. Because again, there's really two big things that can cause this TSH-dependent thyrotoxicosis. We've got a TSH secreting pituitary adenoma and thyroid hormone resistance. So one of the easiest things we could do is get a brain MRI and see, hey, is there a tumor there? So again, management will usually observe genetic counseling. We could get endocrine involved, right? They're the experts here. So again, my pearl for this one is the TSH looks inappropriately normal or potentially elevated because the peripheral tissues are partially blind to your thyroid hormone. So again, do not get confused for both of these diseases. It is a TSH dependent process. And by that, I mean my TSH is not low, okay? Normally when T4 and T3 are high, it suppresses TSH and TRH. So the fact that the TSH in both of these cases could be normal or could be elevated is abnormally normal because the T4, T3 will be high due to the production of or the stimulation of TSH. So normally T4, T3 suppress TSH. So if I see that TSH within normal limits, I'm like, yo, that's abnormal. T4, T3 should be making you zero or very, very low. The fact that you're within the normal limit is abnormal, TSH dependent. All right. So how do I further break down TSH independent? Okay, we can break it down two different ways. So pause your screen and think about it. So I can think about increased uptake on radioactive iodine scan or decreased uptake on radioactive iodine scan. So what are the causes of TSH independent thyrotoxicosis with decreased radioactive iodine uptake? There's four of them. So pause your screen and think about them. We've talked about one of them in my pre-case. So they're going to be thyrotoxicosis fictitia, iodine excess in the Jode-Basedow phenomenon, extraglandular like struma ovare, or thyroiditis like my subacute, silent, and postpartum. Okay, so we'll talk about thyrotoxicosis fictitia first. So this is incidental intentional or accidental ingestion of exogenous thyroid hormone. So the patient is taking in excess thyroid hormone via a pill, right? That will lead to an increased T3, T4, because usually we give them levothyroxine, right? They take in the T4 and then it gets converted to T3 in the peripheral tissues. That'll feed back and it will shut down the production of TRH and TSH. So then there's no actual stimulus to the thyroid itself. So my thyroglobulin levels are really low because remember, thyroglobulin is made when we add an iodine to tyrosine. We're not doing that process because your anterior pituitary and hypothalamus think you have made all the thyroid hormone you've ever needed, so it doesn't need to work, right? But really, the patient is taking drugs exogenously. So again, the pathophys, we have the exogenous hormone suppresses endogenous production via what I just said. The radioactive iodine would be decreased, okay? So remember, the thyroid loves iodine. But in this case, because they're taking in T4, which is getting converted to T3, it's shutting down TRH, it's shutting down TSH. There's no stimulus to my thyroid hormone. There's no thyroglobulin being made. There's nothing to take up the iodine because the thyroid tissue is like it's basically like a think about your thyroid hormone, your thyroid gland, sorry, as a factory. In this case, the factory is shut down, right? The key to turn on the factory is TSH. We've turned off that we've gotten rid of the key, right? We've turned off the key because T4 feeds back and it shuts down TSH. So we've thrown the key away so the factory remains closed. So me giving iodine, it's not able to get into the factory, so the uptake is really low. Okay, so management, we stop their exogenous hormone use, right? So my pearl here is the low thyroglobulin because my thyroid it's not needed to function. It's not functioning right now because it's getting all the exogenous thyroid hormone it needs. We want to think about an exogenous source, all right? My iodine excess, the Jode-Basedow phenomenon, is hyperthyroidism after iodine exposure. It could be just they get a huge bolus of iodine, they get radioiodine contrast, or amiodarone can cause this too. Amiodarone contains two iodide molecules, so when we give it in high enough amounts, it can actually cause this. So again, we'll see high amounts of T3, T4, low TSH, and in this case, high amounts of thyroglobulin. The pathophysiology here is we have excess iodine triggers autonomous hormone production in susceptible thyroid tissue. So I give them enough iodine that it actually causes increased production of my thyroid hormone. And so in that case, the thyroglobulin is going to be elevated, all right? And it's going to be elevated because we're giving it the iodine it needs to make the hormone, all right? So really, in this case, the radiodiodine can be variable. It can be decreased or normal. It really depends. The thing is once I give it the iodine excess and it's used up all the iodine excess, now at this case, the patient's going to definitely be hyperthyroidism, right? Because let's say I give them a bolus of iodine, they use it all to make just a ton of T3, T4, and we release it, right? The patient's super hyperthyroid, but now the problem is we've gotten rid of all that iodine and the thyroid hormone shuts down or the thyroid gland shuts down because it's like, hey, I just made all this T4, T3. It feeds back, it shuts down TRH, it shuts down TSH. So then it shuts down we've taken the key and we've thrown it away. The factory remains closed. So usually you're going to see decreased uptake unless you catch the patient right after they took the iodine bolus, which you never will, because we're not going to test them for this until they start having the hyperthyroidism symptoms, which will be a little bit later. So again, we stop the iodine exposure. We can give thionamides if needed. And then again, I want you to think about Jode-Basedow is an iodine jumpstart to autonomous tissue, right? So I give a huge bolus of iodine, it jumpstarts the thyroid hormone or the thyroid gland. We dump a ton of T4, T3, but now that feeds back, it shuts down TRH, it shuts down TSH. TSH is my key to my thyroid gland factory. We throw away the key because TSH isn't working. My factory remains closed. It's not going to uptake iodine. All right. We can think about extraglandular. Extraglandular is classically going to be the struma ovari. So this is an ovarian teratoma that secretes thyroid hormone. So we have an increased T3, T4, a decreased TSH, and an increased thyroglobulin. T3, T4, decreased TSH, increased thyroglobulin again. So we have ectopic thyroid tissue in the ovary that's producing the hormone. All right. It'll lead to decreased uptake in the thyroid tissue. That's because the T3, T4 feedback, they shut down TRH, they shut down TSH. TSH is my key to my thyroid gland factory. If we don't have TSH, we throw away the key, the thyroid remains suppressed, and there's going to be decreased uptake of iodine in the thyroid because the thyroid factory remains closed. That was why that was our answer for our case today, because that was the only option, right? Here are my four options of decreased uptake in TSH dependent or sorry, this should say TSH independent thyrotoxicosis. Um, and so with that, sorry, independent. There we go. So with that, the tumor ovaria was the only plausible answer, right? So to manage this, again, we surgically remove the ovarian teratoma, the tumor. We think teratoma in a young woman with hypothyroidism with low RAI uptake. So again, it's a teratoma in the ovary that can ectopically secrete T4, T3, feeds back, shuts down TRH, shuts down TSH. There goes the key to my factory. My thyroid factory remains closed because it thinks it knows, like our brain senses, hey, we're getting all the thyroid hormone we need from some extra source, right? And the patient could present in hyperthyroidism type symptoms. And then we have thyroiditis. So thyroiditis, I'm going to go into depth on the causes when we do our hypothyroidism lecture, but we have different causes that cause over like production and over secretion or excretion of my thyroid hormones. And then the thyroid is like all out of materials. So then it becomes hypothyroid, right? So classically, we have a hyperthyroidism phase followed by a hypothyroidism phase. So we secrete or excrete all of my thyroid hormone. The patient will present in hyperthyroidism type symptoms. And then we've lost all of my pre-made thyroid hormones. And the thyroid gland is like, yo, dude, I've got nothing left to build. And because of all these excess T4, T3, it feeds back, it shuts down TRH, shuts down TSH. TSH is the key to my thyroid gland. We throw away the key, the thyroid factory remains closed. If I try to give it radioactive iodine to see does it go into the thyroid, it's not going to go because the factory is closed. So again, the pathophys is it's an inflammatory release of preformed thyroid hormone, and I'll go into the specific causes when we do our hypothyroidism lecture. Again, it's decreased uptake due to the gland shutdown. We've released everything. The gland's got nothing left to give. The excess T4, T3 feedback and shut down the whole HPT axis. We can treat them supportively. Classically, your best answer on a board exam is going to be beta blockers. So let's treat them symptomatically. We don't give thionamides like methimazole or PTU because it's not a problem in the thyroid gland itself, right? There's nothing to suppress here. It's we've released all these pre-made hormones. So we need to just stop symptomatically. Let's give them a beta blocker to stop them from upregulating all these adrenergic receptors, or right, they're going to increase the adrenergic receptors. Let's at least give them a beta blocker so that we can stop norepi and epi from binding to those receptors to begin with, right? So my pearl for this one is it's an inflammatory dump. You get hyperthyroidism first and then hypothyroidism. All right, almost done. So how can we further break down TSH independent thyrotoxicosis with increased uptake? I can break it down two ways. All right, so we can break it down into diffuse uptake of the radioactive iodine or focal uptake of the radioactive iodine. So let's think about TSH independent thyrotoxicosis with increased uptake, both focal and diffuse. So Graves and beta HCG mediated are going to be my diffuse, and toxic adenoma and toxic multinodule goiter are going to be my focal. So Graves, we classically have our hyperthyroidism symptoms, often with my exophthalmos or proptosis, because again, those TSIs go up to my fibroblasts, they bind to the TSH receptors or the IGF receptors. They cause increased production of glycosaminoglycans and push my eyes forward. We can also see pretibial myxedema. I've got a picture of that coming up. It's basically glycosaminoglycan deposition into your anterior shins, and they look very doughy. And we could see a bruit on thyroid, okay? So normally if you ever hear a bruit on the thyroid, you should think Graves' disease, because that tells me massively diffuse expansion of the thyroid gland, okay? So labs, we're classically going to see decreased TSH, increased T3, T4, and increased TRAbs. So those are the thyroid receptor antibodies. They're also called TSIs, thyroid stimulating immunoglobulins. If you ever see these, they're exactly the same. TRAb and TSI are the same. So the TRAb or TSI stimulates my thyroid. The thyroid then makes T3, T4. T3, T4 feed back, and they shut down TRH and TSH. So T3, T4 are high, TSH is low, and if we test for them in the antibody or in the blood, the TRAb or TSI will be elevated. So again, we talked about the pathophys. So the radioactive iodine, it's an autoimmune process. So it's going to stimulate the entire thyroid gland itself. So the whole thyroid gland is going to be overproductive. Okay. So the whole thyroid gland is going to take up this radioactive iodine, right? The TSIs and TRAbs are constantly stimulating every part of the thyroid to make more hormone. So when I give this radioactive iodine uptake test, the whole thyroid hormone will be overactive and will take up way more of that radioactive iodine. The management, again, we've talked about it. We can do the anti-thyroid drugs, we can do ablation, we can do surgery, and we can do steroids or teprotumumab for the proptosis. My pearl, when you see TSI, it's Graves. It's the only one with the eye findings. Okay, the only way we get those proptosis is because the TSIs can also stimulate the TSH receptors that are found in my eye fibroblasts and those IGF receptors found on the eye fibroblasts. So whenever you see proptosis, think Graves. All right. We have beta HCG mediated. So remember, beta HCG can weakly stimulate the TSH receptor via molecular mimicry. So when I have super duper duper high levels of beta HCG, like in molar pregnancy or choriocarcinoma, it can cause hyperthyroidism, right? So look for a patient who's pregnant or look for a patient who has a choriocarcinoma. Choriocarcinoma can occur after molar pregnancies and it can metastasize to the lungs. So those are all kind of key things for me to look for. So this beta HCG is going to act like TSH and it's going to stimulate the thyroid hormone and it's going to make increased T3, T4. The thing though is T3, T4 feeds back and it shuts down TRH and endogenous TSH. So the patient's TSH is going to be very low. That's because their beta HCG is sky freaking high and it's acting like TSH via molecular mimicry. Right? And then obviously their beta HCG will be very high, so we can test for that. So you're going to see diffuse increased uptake again, because the beta HCG is going to cause super duper high, or you have super duper high levels of beta HCG. It's going to stimulate your whole entire thyroid. My whole entire thyroid is overactive. The whole entire thyroid will uptake more iodine. So again, treat the underlying cause, either evacuation of the mole or treat the choriocarcinoma, and we can treat with beta blockers if needed. So my pearl here is HCG cross-reacts with TSH receptor. Look for pregnancy clues. And then we have our toxic adenoma. So these next two would be focal uptake of the radioactive iodine. So we'll see focal symptoms if it's a large nodule. So they might have like one large part of a goiter, not a huge diffuse goiter. Again, these toxic adenoma, it's one small hyper-functioning follicular nodule. So like one part of the thyroid, right? We have two thyroid lobes. One part of it has gotten bigger and is autonomously secreting. Whereas in Graves, the whole entire thyroid is lit up, but the whole entire thyroid is massive and secreting T3, T4. Same thing in the beta HCG mediated. In this case, it's one small part of it that's going to make increased T3, T4. It's going to cause all your hyperthyroidism symptoms. It's going to feed back, shut down TRH, TSH. So again, when we do the radioactive iodine uptake, that one spot that's overproducing thyroid hormone is going to take up all of that radioactive iodine. The rest of it is not, right? The rest of it's normal functioning thyroid tissue. And actually, if we're over secreting from one side and then we're decreasing the production of TRH, TSH, then we don't have the TSH signal to increase the production of thyroid hormone from my other side without the nodule. So that other side is actually not going to light up really at all because it's got no stimulus at all. It's really just the one side that's taken over. So for that, we can use anti-thyroid drugs, radioactive iodine ablation, and surgery. And so again, my pearl here is if you see a single hot nodule, think about the toxic adenoma. And then lastly, the toxic multinodule goiter. So again, in this case, instead of just one nodule, we see multiple nodules. So we've got multiple different nodules that are going to secrete increased amounts of T3, T4, feedback, shut down TRH, shut down TSH. We take the key, we throw it away. So then the TSH is very, very low. We see when we do your radioactive iodine uptake, we'll see many spots of focal uptake. So again, Graves is diffuse. Beta HCG is diffuse because the whole thyroid gland is just getting lit up by the TSIs and by the beta HCG respectively. In toxic adenoma, it's one small part of the thyroid over secreting. And in toxic multinodule goiter, it's multiple small parts. So focal parts will light up. Again, we can use anti-thyroid drugs, radioactive iodine ablation, and surgery. I want you to think about an elderly patient with a patchy uptake. Think about multinodule goiter. All right. I've got just a few pictures for you. This is how it might show up. Like obviously they show you a real picture, but Graves' disease, the autoimmune process is stimulating the entire thyroid. So really the whole thing's going to light up when we do the radioactive iodine uptake because the whole thyroid gland is overproducing. When we have a solid nodule, right, that one part is going to light up. The toxic multinodule goiter, all those focal parts will light up. Thyroiditis, none of it's going to light up if we catch them after they've dumped all their thyroid hormone out. So they've got nothing left, right? And the T3, T4 are feeding back and shutting down production of TSH. So there goes the key thrown out the window. So the thyroid factory remains closed. And thyrotoxicosis fictitia, right? They're taking exogenous T4, it's getting converted to T3. They get their hyperthyroidism symptoms, but again, it feeds back, shuts down TRH, shuts down TSH. So there goes my key to my factory. My thyroid factory remains closed. It's not taking up any radioactive iodine. Physical findings. Here's a picture of proptosis. So again, the TSIs or the TRABs can stimulate the orbital fibroblast via the TSH receptors and the IGF receptor and can cause increased production of glycosaminoglycans, which push the eye forward. Here's your pretibular myxedema, that doughy skin, right, because of glycosaminoglycan production. And then this is something called plumber's nail, where we get kind of the nail bed raises higher than it should. It's a class. It can be seen in a lot of different diseases, but it's classic of hyperthyroidism. Okay, so just some physical exam findings you might see. So again, let's do our schema one more time. We have thyrotoxicosis. If it's TSH dependent, meaning the TSH is either elevated or it's abnormally normal, because my T4 and T3 are sky freaking high, it should normally shut down TSH. So the fact that it's normal is abnormal. We're thinking about a pituitary adenoma or impaired sensitivity to the thyroid hormone. If we see my TSH is low, right, in the setting of high T4, T3, I can think about it in terms of increased uptake or decreased uptake. So if I see high T4, T3 and low TSH, my next step could be a radioactive iodine uptake to help me tell the difference, right? If there is decreased uptake, that could be due to exogenous thyroid hormone ingestion, thyroiditis, where we have thrown out all my thyroid hormone and now my thyroid tissue is closed down, iodine exposure via the Jode-Basedow phenomenon, or extraglandular via struma ovari, right? If it's increased uptake, we can then look at the radioactive iodine scan and say, hey, was this diffuse? And maybe it's Graves. We could test for the TSIs. Or is this beta HCG induced? Was the patient, is she pregnant? Was she just pregnant? Does she have metastasis to the lungs, right? Are we thinking choriocarcinoma? Or was it focal, right? Is it one spot? Is it a toxic adenoma? Or is it multiple spots? Is it a toxic multinodule goiter? So again, this is the framework I use to think through any thyrotoxicosis. It works beautifully. You just have to practice with it, practice. Rewatch my lecture to try to understand further. We'll do two quick cases to put it all together. We have a 34-year-old woman with a history of Graves' disease. She undergoes total thyroidectomy after failing medical management. On post-op day 2, she develops new onset perioral tingling, muscle cramps, and mild confusion. Physical exam reveals a positive Chvostek sign. Lab studies show a very low serum calcium, a elevated serum phosphate, kind of within normal limits serum mag, and a very low PTH. Which of the following EKG changes is most likely to be observed in this patient? Will we see peak T waves, shortened QT, prolonged QT, or ST segment elevation? So pause and think about it. So in this case, when I have very low calcium, we're going to see prolonged QT, right? So this occurs due to the prolonged phase 2 of the cardiac action potential, which can then cause a prolonged QT interval. So the way you think about it is low calcium causes long QT, high calcium causes short QT. So again, when the calcium's really low, it prolongs phase 2 of the cardiac action potential and causes that long QT. Low calcium, high QT. High calcium, low QT or short QT. Really, I told you why this patient has hypocalcemia. If you listened right earlier, sometimes when we take out the thyroid, some of those parathyroids can come with it. And with that, we lose our parathyroid hormone. I'll go into the whole axis of parathyroid hormone at a later date. It's too much to go into now. But without parathyroid hormone, I can't maintain my calcium balance. When calcium dips low, we can get a lot of the symptoms we saw here, right? So perioral tingling, numbness tingling in my fingers and toes, muscle cramps and confusion are all classic. when I tap the facial nerve around the cheek, and it kind of causes a jaw reflex that's called Thyrotoxicosis. I can wrap a blood pressure cuff around the arm and constrict it. And if the patient's finger, if their hand spasms, that's called Trousseau's sign, which is another sign of hypocalcemia. So again, low calcium, long QT. If you want to read more about it, here you go. And then the last one, we have a 72-year-old woman with a history of poorly controlled hyperthyroidism. She presents to the ED with agitation, confusion, and disorientation. The family reports that she recently developed a fever and productive cough. On exam, she's febrile to 103.1, heart rate's 138, the blood pressure 156/88, and she has a fine tremor. She's disoriented to time and place. The EKG shows AFib with RVR. Lab studies show a TSH that's very, very low. A free T4 is elevated. The glucose is 64. AST, ALT mildly elevated, the leukocytosis with a left shift. The blood cultures are pending. She's admitted to the ICU and started on empiric antibiotics. Which of the following best explains the altered mental status? Does she have cytokine-mediated septic encephalopathy? Does she have direct hyperthyroid-induced neurotransmitter regulation? Does she have cerebral hypoperfusion due to high output heart failure? Or does she have neurotoxic accumulation of ammonia from hepatic dysfunction? So pause, reread, and think about it. So in this case, it is going to be direct hyperthyroid-induced neurotransmitter dysregulation. Hyperthyroidism, especially thyroid storm, is a very well-known cause of delirium or encephalopathy. The mechanism is we increase the cerebral metabolic rate, which alters the neurotransmitter turnover, increases my sensitivity to catecholamines, and can lead to our agitation, delirium, psychosis, and potentially even coma. So the key point is a CNS dysfunction often exceeds what is seen in sepsis or high output failure. And really, we can get rid of the wrong answers because in septic encephalopathy, it's less likely because really in this case, right, I see a nice blood pressure here. We see a fine tremor. We see AFib. We have the classic thyroid pattern here. It's going to point me more towards thyroid-induced like thyroid storm. You could potentially make the argument of cytokine-mediated septic encephalopathy. I don't know if this question would fully hold up on an USMLE exam, but for the sake of this, I was trying to just show you guys what thyrotoxicosis delirium kind of looks like and what you should consider. Cerebral hypoperfusion, again, the patient is hypertensive, not hypotensive, so that doesn't make sense here. And ammonia accumulation requires advanced liver failure. Her AST and ALT were only mildly elevated. So again, the whole point of this exam or this question was to show you that thyrotoxicosis can cause delirium. It's a very well-known cause, and it's something that should be on your differential, should be on your radar. Any patient with delirium, you could consider getting a TSH because actually both hypo and hyperthyroidism can cause delirium. All right, so we went over a lot. So again, here's your mechanism one more time, thyrotoxicosis. We can think about it TSH dependent or TSH independent. If it's TSH dependent, we think about pituitary adenoma or an impaired sensitivity to thyroid hormone. If it's TSH independent, we can do a radioactive iodine uptake. And if we see a decreased uptake, we think about exogenous thyroid hormone use, thyroiditis, iodine exposure, or extraglandular like struma ovare. If there's increased uptake, we can think about, is it diffuse? Is that Graves or HCG induced? Or is it focal? Is it toxic multinodular goiter? Or is it a more like a single nodule, and is a toxic adenoma? So again, with this is a lot, so please go through this as many times as you need to. Reach out to me via email, and I'll keep on coming.